Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello and welcome to another podcast from AAOMPT. This is Kevin MacPherson, and we are continuing our series of interviews that occurred at the 2018 AAOMPT Conference in Reno, Nevada. In this interview, we will be speaking with Cody Mansfield, who is a physical therapist who has undergone quite extensive training, starting with an athletic training degree from Chapman University, a doctorate in physical therapy from Duke University, and then residency and fellowship training from The Ohio State University, of which is also the location of his current PhD studies looking at rehab sciences. Now, Cody's specific talk here is looking at medical screening and differential diagnosis, which is subject of his two lectures at the AAOMPT conference. So without further ado, let's get into it. So Cody, tell us how the conference is going for you so far.
So far, so good. I always like coming out to the AAOMPT conferences. The AAOMPT organization has always had a big impact on my career, and I believe this is my third or fourth one coming to. So it's always an exciting time to see all the fellows in training and kind of meet people in a smaller type conference. So it's been good so far.
It seems nice to also have that shared interest in this conference, where a lot of other conferences are a little bit more spread out against, whether you're focused in this type of PT region or this type of professional region where it's really condensed. So a lot of people are interested in the same thing. It's one of the reasons why I love our conference. But speaking more specifically to you, you've got two talks that are going on. Why don't you tell us a little bit about how they're the same or how they're different?
Yeah, so my colleague Phil Toll and myself, we submitted a proposal to AAOMPT to present on medical screening for manual therapists. So it's titled Advanced Screening for the Manual Therapist. However, what the audience will find out is that it's really all about the basics. And it's going to be a really engaging talk. I'm hoping we get a good turnout for it. Phil and I, we initially met through one of our colleagues who set up a meeting between fellows that live and work in Ohio, and we had a fellows weekend. I really liked Phil Toll's piece on assessing medication use and GI distress and how that can cause low back pain. So that's kind of his piece right there. And I asked him, hey, would you want to propose a topic to AAOMPT? And we did, and we're very thankful they accepted the proposal. I think the audience is going to get a lot out of it.
Yeah. So personally, what is it about medical screening that really has stimulated your interest?
So I work for a sports med clinic at Ohio State University, and I'm in the suburbs, so I end up treating anyone from your high school athlete to your grandma and everyone in between, even though we're a sports med clinic, right? And part of my role at OSU is also mentoring our residents and fellows. And there are just so many situations that our residents, fellows, and clinicians just get put in where the patient has some odd symptoms and we just need more information. And what really got me passionate about this topic is specifically just taking people's blood pressure and how can we bring, make that the norm for our providers taking blood pressure, where really I think we make a lot of assumptions working for a sports med clinic thinking, hey, all our patients are athletic and they're coming to see us, when really it's far from it. And especially when we're in the suburbs and we treat such a wide range. We've really worked on changing the culture within our own clinic and hopefully eventually all of our whole institution. But the biggest way we've impacted the culture at our clinic is buying a top-of-the-line automated blood pressure cuff, where now it's efficient for our PTs to use it. Really a manual blood pressure cuff in a PT clinic, it's difficult to use. You're trying to document, you're holding their arm, it's just a mess. On top of it, not all the time are we in a private exam room. There's a lot of noise, there's probably some inaccuracies in that reading. I think everyone feels a lot more a lot more reliable and valid just with this automated blood pressure cuff. And I think the use of it has gone up tenfold since we've bought this one piece of equipment. I think we're already thinking about buying one more just to make sure we have it available.
All right. The entry fee should be that blood pressure, right? That should be one of the first things that's objectively measured. And I do agree. I think even self-wise, prior to getting into medical screening from a teaching standpoint, it was kind of like they're ambulatory, that's good enough. Or hopefully somebody else is dealing with it. And then going through a lot of my own medical testing and whatnot, it seems to be a sore point across a lot of different professions. In that I've definitely had practitioners who, for whatever reason, I'm all of a sudden really close to 120/80, or I've got the wrong blood pressure size because the clinic doesn't have the right blood pressure cuff size, or things along those lines. So I like the idea of us doing it personally, but also that grand scheme, like we're part of a larger system.
Right.
So
Yeah, and I think ideally as we keep going with the culture at our own clinic, me and my manager were discussing ways to get our providers this information before they even grab the patient from the waiting room. Because really, to be an expert clinician, to catch things before they're a problem, to know this information before you exercise someone who's hypertensive or do a manual technique, you maybe would change your management if you have their blood pressure reading beforehand.
Mm-hmm.
I'd say at our clinic right now, we recommend everyone do it at the evaluation.
Mm-hmm.
But I'd say more often than not, people just do it when they are concerned about their patient experiencing symptoms. And so we're still trying to affect the culture within our own clinic. And one way that me and a few of my colleagues are doing it are leading by example. So taking patients' blood pressure, our colleagues see us doing this. And then also mentoring our residents and fellows, and probably to a fault, I think I'm a little too easygoing with them. Like just last week, I mentored one of our fellows, and there's someone who is healthy, in their 30s, referred to us for migraines. And at the end of our mentoring session, we did a debriefing, and I was like, oh, you know what? Like, I know we're pressed for time, but you probably should have taken their blood pressure. The patient then follows up with me the following week, has some dizziness, some concerning symptoms. I take their blood pressure. And it was fascinating because it gave me some information as to she was extremely hypotensive. Mm-hmm. And it led to a really interesting discussion about the primary care physician prescribing blood pressure medication to manage her migraines. So now as a provider, I'm like, well, one, is this inappropriate for you because your blood pressure is a little low? And now I need to talk to the physician and just get a better understanding of what's going on. Yeah. So I think we just make way too many assumptions about our patients because they're able to walk into our clinics. And what's wrong with more information? Yeah,
I mean, that's a really good example of larger context to that patient case. And also bringing in another profession because there's that cost to benefit ratio. What's the cost of decreasing our medication relative to the migraines and that impact on function in life?
Right.
So that's I guess I haven't thought about it as much to that level. So that's an excellent example. Now I'm curious, if we think about different procedures that ideally should be done in a profession, take the aviation industry and then the surgical industry and how they've implemented checklists. What are your thoughts on trying to move to a checklist format for some of these easier, low-hanging fruit measures in your system, in a wider system?
What an interesting idea. Because I feel like we all get into situations where we only have a 30-minute follow-up with someone, or all of a sudden one patient requires more time, and we just frankly, we prioritize certain tasks. Mm-hmm. And however, it's not like you have your pilot, just overlook the brakes aren't working,
Yeah.
I think that's an excellent idea. And, one thing I'm interested about the presentations that me and Phil are giving today is other people approaching us. I'm going to ask the audience, what are you guys doing in your clinics? Like, or what innovative ideas do you guys have? Because we're still in the thick of it. Literally, we've just bought an automated blood pressure unit, and that's affected the change in a little bit. But it's tough when you're a high volume clinic to implement this standard. So I like the idea of a checklist. I'll probably bring it up with my manager.
So Cody, one of the things that I saw in the description of your presentation is looking at palpation of the abdomen and screening the abdomen. One of the things that I do when I teach that component to my students, or when I run into when I teach that component to the students, is, well, who am I doing this on? When am I doing this on? So I'm curious as to what your threshold is to say, I probably need to do an abdominal evaluation.
It's a great question. I mean, first off, if anyone reports quadrant pain in their abdomen, that's a clear sign that you need to ask the appropriate screening questions, palpate the quadrants, look for rebound tenderness, things of that nature.
One of the things that I've done with the students, especially, and it might pan out in your talk because you haven't given it just yet, so I'm not certain, but one of the things I also try to get them to use as a threshold to maybe look at that abdomen would be a failure to reproduce the sign, especially if it's more of that shoulder type referral, so more that diaphragmatic referral, or looking liver, spleen, pancreas. When they kind of have this nebulous, it kind of has a mechanical component, but there's this other underlying pain that just doesn't seem to be able to be reproduced.
Could you give us another idea of an assessment that you would do for some of these outlier type patients that need referring?
I feel like we always train our fellows and residents for the zebra diagnosis,
Yes,
but I mean, auscultation of the abdominal aorta, I mean, that'd be important to do. And you know, I know in research we kind of push back. Those studies are done in the 90s, 80s, and so on. But I love the resident case reports that are published in JMMT and JOSPT. There's a great one by Dr. Boisenaud, actually, where a woman or man, like 35 or something, complained of low back pain. Not your typical presentation of someone presenting with a AAA.
Yeah.
Very thin build too, not your older male kind of person you would think would have it. And Boisenaud and his resident, they did palpation, auscultation, and it was a huge AAA.
Yeah.
And I love that article too, just because it's you see Dr. Boisenaud with suspenders, and they actually have a video to accompany it, so it's a great way to learn how to auscultate and to listen for the sounds. So that's another thing we teach our fellows. Again, we probably raise more false alarms than anything.
Yeah. Cody, what else might you be looking for with patients that come in through the door?
My wife, who's a physical therapist as well, she works with a pediatric population and has really worked on women's health. And she's developed a really good relationship with a physician who treats young women with endometriosis. And they end up having a lot of abdominal pain. And so I'm learning more about those kind of situations. And I will say the nice thing about being at OSU is we have such a hierarchy of fellowships and residencies that, you know, if something from the orthopedic or orthopedic manual physical therapy fellow perspective, if someone isn't fitting our picture, and let's say they're a woman with low back pain or perhaps a guy as well, we'll sometimes just refer them to our women's health physical therapist and get a consult from them. And that always leads to some interesting inner physical therapist dialogue with different specialties.
I have also noticed that my flag is like raised a little earlier than I think a lot of people are, and even to the side of maybe excess. But I love the idea of opening up that referral process because it allows you to get better vantage points. Speaking directly to the example you gave, I didn't start working with a pelvic health therapist until probably 8 years into my practice. And it was like, God, I've been missing a lot of patients with back and hip pain. And knowing more of those patterns, or at least being familiar enough to know who to send it to, is key. So now let's talk about advice you give, and not so much to your residents per se or your fellows, but those new grads or even those students who are on their final internships, to help them make sure that they're keeping those non-PT related diagnoses in the back of their mind. So those referral type diagnoses.
Well, you just recently had my first physical therapy student from University of Findlay. And me and my colleague were mentoring her, and I think my colleague and I were just so biased because we love residencies and fellowships that we convinced her to apply for residency. But to keep those diagnoses in your mind, I think it's tough when you're a physical therapy student, because not only are you responsible for orthopedics, but you're responsible for all these other subsections. And when you want to focus in on orthopedics or sports, you just have so much information. And I think you've already learned everything, but now it's how do you apply it to a clinical situation, and how do you operate in that gray area? And that's why I love residencies and fellowships, or clinics that offer that mentorship piece. You not only our residents and fellows, but our colleagues with the same level of experience at our clinic will sometimes bring each other in on cases when, like, hey, this isn't making sense. And bringing in all of our perspectives on one case is a good idea. So for that new grad, again, I think getting a mentor that really cares about your development is probably the biggest advice I have. And then feeling like you're in an environment where you're able to bounce ideas off them without being afraid of making a mistake, I think is important. And just creating that good learning environment for those complicated patients where it could be an orthopedic issue, it could be an issue that requires a referral.
So Cody, now that I've got an idea of what you've looked at and the way you look at the system, the way you look at the body, and also how you look at trying to help out other newer practitioners when it comes to medical screening process, do you have any other projects that are in the pipeline? Do you have any other things that you're hoping to build up for other presentations?
Absolutely. So I have a few. One that has been a labor of love, and that I'm sure someone will ask me to update it soon, is my colleagues and I just had a manuscript accepted to JOSPT titled, thank you, it's titled The Effects of Needling Therapies on Muscle Force Production, Systematic Review and Meta-Analysis. And it should be coming out ahead of print this month. It'll be actually in the Physical Journal in March 2019. And I will say the reviewers and editors from JOSPT were very kind to this project and really helped it along. I submitted it initially as a systematic review, and they're like, oh, well, why don't you try a meta-analysis with it? I'm like, well, I guess I need to learn how to do a meta-analysis. But my colleagues were very, the co-authors were instrumental in that project. But there's that project. Back to the medical screening piece, we were kind of talking about it before, but last year at the AAOMPT Conference, I presented on a case I was super passionate about. A patient referred to me for lumbar radiculopathy and subsequently was diagnosed with cervical myelopathy. And after my first visit with them, I felt like I was like, man, I'm a fellow of AAOMPT. I know this is cervical myelopathy. And then I was like, I'm going to do this super thorough exam. Maybe it's upper cervical instability too. So I do a sharp Purser's test. And it was positive. And so that threw me for a loop. So all of a sudden, my clinical decision making was perfect. Then I did this test, and it was ruined. And it still led to X-rays and MRIs, the patient ended up having cervical myelopathy, getting surgery and all that. But more of a kind of a theoretical project. I'm very curious if the application of the sharp Purser test, could it be applied to other clinical populations? Because you read all the case reports in the literature, you read the RCTs out there that use it as a screening test. What if we changed our definition of the sharp Purser test to not only include upper cervical instability, but any kind of central cord issue in the upper cervical spine? So one project I have down the pipeline is, and maybe with our future fellow in training, is looking at every study case report that use the sharp Purser test. And basically the two aims of this project would be, are there any other diagnoses that were found either as a positive or negative test? And then also, is this test truly dangerous? There was Dr. Meadows published clinical commentary on the test a long time ago in JMMT saying, is this just a test that's futile? So another idea for this project would be, is this dangerous at all? And from my preliminary research, it seems like the sharp Purser test, whether it was upper cervical instability or something else, actually helped the provider gave the provider more credence to refer the patient out. And at least in the published literature, there was no dangerous mechanism. So that's another future project, and it's just because I'm super passionate about this case. But I talk about that case briefly in the talk today.
The Paul Mintkin, I believe, published a description piece. I want to say it was looking at upper cervical instability, but he goes to the reasoning process of when to apply, say, the sharp purser as opposed to the transverse ligament test, alar ligament testing. So that might be another one that you can add in there and see what kind of references he used too.
Yeah, definitely.
So that's great. We're looking forward to those projects. So the last question that I have for you is, what advice would you give a practitioner who's kind of on that fence as to whether or not they want to take a fellowship and take on that challenge?
When you're looking at fellowships, I think you got to find the right one for you, and I think you got to think about what you want to get out of that fellowship, and also what model works best for you. So the director of our program, Jake Bleacher, and our former co-director, Paul Tadak, they couldn't afford to go to a place and do a fellowship where you take a pay cut and do those sort of things. They required a different model, more the weekend intensives, online training, having a mentor come to the clinic or going out there. On the flip side, I went the other route where I went to the fellowship at OSU Sports Med, and for me that was a really good decision. I was already in the system. You do take a small pay cut, but for me it was worth it because they offered teaching experience, leadership training, and for me the big thing was research training and developing stronger relationships with our research staff and providing our orthopedic and manual therapy focus to some of those projects. So it's all about what you want. The research aspect for me was really important and why I chose OSU. And then there's something to be said about working 8 to 5 and sitting between your mentors. I mean, I think that's a piece that may get lost with the weekend intensive fellowships, but they all have their strengths, they all have their weaknesses. At the end of the day, you're going to be better by being more self-reflective and by being mentored. So I'd say pick the one that's right for you and join the academy, be a part of the fellowship. I think everyone that I know has gone through it has never regretted it. Yeah. So there's something to it, and I hope people consider to do them continuing from here. Yeah,
that's great advice and things that somebody who's on that fence really should consider. So, Cody, if there are listeners who want to reach out, get in touch with you, ask you questions about your presentations, your future work, what's the best way for them to get a hold of you?
So typically I post updates on research and poster presentations that my group and I publish and perform on my Twitter handle. That's simply @MansfieldCody.
Okay.
And that's probably where I give out the most information. Otherwise, you can find out more information about our residencies and fellowships on the Ohio State University Sports Med website.
Fantastic. Well, Cody, have a wonderful rest of the conference and good luck with your talks.
Great, appreciate it.
All right.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.